So welcome, and thank you for joining us for Hanger Clinic's virtual classroom designed for medical professionals. It's great to see so many of our regular attendees out there today and some new folks out in the crowd as well. So today we have Hanger's Clinical and Scientific Affairs team joining us for an in-depth look at the recently published OASIS-1 study. I want to turn it over to my colleague, Molly McCoy, who will bring up here, and you'll be all set. Hey, Molly.
Hey, Lily, thank you. All right, so thank you everyone for joining us today. And before we dive into OASIS-1 study, a retrospective analysis of 4 different microprocessor knee types, I'd like to introduce our panel of experts here with us today. We have Jim Campbell, Senior Vice President and Chief Clinical Officer for Hanger Clinic. Dr. Campbell is a certified orthotist, a fellow of the AAOP, and a member of the International Society for Prosthetics and Orthotics. He serves as Hanger's Chief Clinical Officer. We also have Phil Stevens, Director of Clinical and Scientific Affairs. Mr. Stevens develops evidence-based programs for Hanger Clinic designed to help patients improve their orthotics and prosthetics outcomes. And last but not least, we have Shane Werdeman, Director of Clinical Research. Dr. Werdeman has published numerous studies in peer-reviewed journals. In addition to his research work, he continues to manage a patient caseload with Hanger Clinic. So we'll start with Jim. Welcome.
Thank you. Good morning, everyone, and I'm delighted to welcome all of you to our webinar this morning. We very much appreciate and are so encouraged by the level of interest in our work and specifically the level of interest in this publication. It's only 4 weeks ago that we published this manuscript in the Journal of Rehabilitation, Assistive Technology and Engineering. Our purpose was to compare outcomes from 4 commonly prescribed microprocessor knees, specifically to compare outcomes in 4 domains: the domains of mobility, satisfaction, quality of life, and injurious falls. Let me begin by placing OASIS-1 in context with our broader body of work within the Department of Clinical and Scientific Affairs at Hanger. Our mission is very transparent. Our mission is very straightforward. It's quite simply to explore, expand, and facilitate opportunities that advance the science and care related to the provision of orthotic and prosthetic management. As part of that, we have a desire to strengthen the evidence base. You know, frankly, I think it's more than a desire. I think we have a responsibility and an obligation to strengthen our evidence base. And to do that, we've established comprehensive outcomes tracking and analysis capabilities across Hanger Clinic. We recognize that microprocessor knees are most definitely among the most studied components in prosthetic rehabilitation. However, we also recognize and realize that unfortunately, we're not able to provide clinical guidance as to prescription basis for differing microprocessor types based on available evidence or data. Our goal is to provide our clinicians with evidence, with clinical outcomes and insight that will allow them to make informed decisions that would shape and identify product selection and utilization. The focus for OASIS-1 was placed on the 4 most commonly prescribed and utilized microprocessor knees in the United States. And I think it is important to acknowledge that this study was conducted without any potential bias or influence from manufacturer funding or publication input.
Before we dive into the OASIS manuscript specifically, we thought there'd be some value in reviewing this general construct of integrating evidence into clinical decision-making. Now, for us, this process has begun with the development of our clinical practice guidelines. It's important to point out that as we talk about CPGs, these were never intended to replace the important decision-making that goes on in the clinic. Rather, it's there to inform that clinical decision-making. As we develop CPGs, The goal is to reduce all of the available evidence that's out there into concise, actionable content that can be reasonably integrated into the clinic. With respect to prosthetic knee selection, we began with 9 systematic reviews that served as source documents. These systematic reviews are summary publications that represent data from numerous clinical trials that have been conducted over many, many years and across the world. As we reviewed these source documents, we were looking for evidence statements. These are statements that are supported by clinical trials that address questions of potential benefits associated with the course of care, potential harms associated with a given course of care, and then the comparative efficacy between 2 different courses of care. If you look at the figure on the right side of the slide, what you see is a number of harvested statements that came from these systematic reviews that were used to populate our clinical practice guideline. In an attempt to summarize and organize all these statements into some form or fashion, we broke them down into subtopics. We broke them down into statements that address the relative benefits of microprocessor knees, statements that address relative equivalence of microprocessor knees compared to non-microprocessor knees, and then statements that were germane to a small population of limited community ambulators. To set the stage for OASIS 1, what we want to do is focus in on Recommendation 2 from this clinical practice guideline. Recommendation 2 focuses on the benefits that have been established for microprocessor knees relative to non-microprocessor knees. And what we see here on this slide is that according to the best available evidence that we currently have in the literature, the use of a microprocessor knee is reasonably associated with reported reductions in stumbles as falls, as well as any frustrations associated with those types of events. In addition, the use of a microprocessor knee is associated with increases in things like mobility, satisfaction, and quality of life. Now, what we have in the CPGs kind of brings us through the end of 2017. That's when this exercise was conducted. Obviously, there have been a number of very meaningful publications that have been published since that time. And I would like to defer now to Shane Werdeman to discuss a few of the highlighted manuscripts from recent publication.
Thank you. And thank you to all of our attendees for taking time to be a part of this webinar. I'd like to take a moment to, as Phil said, review some of our recent work as a lead into this OASIS study. First, with MAT3. MAT3 was our initial effort at understanding differences in outcomes for patients with microprocessor knees compared to non-microprocessor knees. Now, at the time of this analysis, we had several thousand outcomes on patients with above the knee amputation and even more with below the knee. This gave us the benefit of being able to implement a matching protocol where we essentially matched patients with microprocessor knees to their peers with non-microprocessor knees based on multi-morbidity status. And it also allowed us to use that same matching technique then to match those individuals to their peers with below knee amputation. Another way to think of this is that we had 3 groups of prosthesis users. One had a microprocessor knee, one had a non-microprocessor, and the last group had essentially a biological knee. We compared mobility across the groups. Now, to assess mobility in MAT3, but then also subsequently in the focus point of today, OASIS 1, we used the Prosthetic Limb User Survey of Mobility, which was developed by Dr. Brian Hafner and his colleagues at the University of Washington. When we look at results in the figure here, these are showing our primary results. Now, on the y-axis is the plus MT score. And then going from left to right are the groups. So first non-microprocessor, and then microprocessor, and then the last one is the below knee amputee group. And what you see is that the advances in technology with microprocessor knee have really closed the functional gap between individuals with above knee amputation versus below knee amputation. And you could say that it's practically cut that gap in half. Now on our next slide, I want to discuss why we focus on mobility, why so many of our prosthetic studies have placed emphasis on mobility. And that's really the connection that we see between mobility and what might be considered more holistic measures of quality of life and satisfaction. Now, if we back up to the first manuscript in the MAT series, so MAT 1, this study, we examined the connection between mobility and these other factors of quality of life and satisfaction. While collecting the plus M for mobility as part of clinical care, our clinicians also capture quality of life and satisfaction through the Prosthesis Evaluation Questionnaire, or the PEQ well-being. By capturing these other constructs within MAT 1, we're able to further examine the relationship between mobility and quality of life and satisfaction. In the figure here, you're seeing that strong relationship between mobility and quality of life. A similar relationship was also found for satisfaction. Mobility, though, is not the only factor related to quality of life. Additionally, it's recognized that the role of falls really within mitigate or improving and helping with quality of life. In this last study, we investigated the role of microprocessor knees in falls, in particular injurious falls. Earlier this year, we presented the results of this study as a Tranhart lecture at the American Academy of Orthotists and Prosthetists meeting. In the SAFE-AMP study that you're seeing here, we assessed the odds of incurring an injurious fall with microprocessor knee use. We specifically focused here on a population of individuals that had amputation due to diabetes and vascular disease. To assess injurious falls in this study, as well as today's focus study of OASIS 1, we analyzed the responses to a single fall question that's routinely administered within clinical care. The question specifically asks whether the patient had incurred a fall in the prior 6 months requiring medical attention. This has the benefit of capturing an injurious fall, which has bigger implications in terms of quality of life, but it also reduces the recall bias, as individuals are more inclined to recall a fall that has resulted in that need for medical attention. We were able to identify 881 K3 prosthesis users that had outcomes. So K3 indicating that these individuals were potential candidates for microprocessor knees. When we ran our regression, we found that individuals without a microprocessor knee were at a 2.5-fold increased odds of an injurious fall. Within this study, though, we had 744 individuals with non-microprocessor knees. Now, because this group was subjected to the same falls question as our sample for today's OASIS study, they also serve as an additional point of comparison within OASIS 1 for our falls analysis. One of the limitations, though, of this study, as well as the other work I shared with you, is that the microprocessor knees were grouped under a single umbrella of microprocessor knee, which would imply that all microprocessor knees are created equal.
So Shane has addressed what really is one of the big limitations in our existing evidence base as we seek to understand the value of microprocessor knees for the lower limb prosthesis user. To a great extent, the guidelines that we have come to associate with microprocessor knees come from studies of the Ottobock sea leg. The work in other microprocessor knees is more limited. We do have several studies on the OSA Rio knee, and most of those are generally positive. However, some recent studies have suggested that we do have some patients that may actually experience an increase in their stumbles and falls as they transition from their non-microprocessor knee to the Rio. They also suggest differences in dampening behaviors compared to other microprocessor knees. When we move to the Orion and the Plie, with respect to published clinical trials, we have very limited evidence, very limited insight. There have been a few very small case series that have looked at the performance of different microprocessors in a laboratory environment, but importantly, these little case studies have all been funded, performed, and published by the manufacturer, which creates at least a risk of potential bias. Now, we know that these microprocessor knees are all different. If we look at the graph here on the right hand of the slide, their mechanisms are different. The sensors they utilize are different. The actuators that respond to those sensors are different. The logic that drives the microprocessors that make those decisions, those are all different mechanisms for our different microprocessors. This creates questions as to how well these different knees might provide the benefits associated with microprocessors in the literature. So as we transition to the next slide here, this is the genesis of the OASIS 1 study, trying to find an answer to those questions. Do we see differences in those outcomes across the different users of the various microprocessor knees? At Hanger Clinic, we continue to collect a number of patient outcomes related to these important variables of mobility, quality of life, and fall history. This rich outcome data provides us with the opportunity to compare these core outcomes between users of different microprocessor knees. So what you see here on the right-hand slide are the demographics of the OASIS study. We had 602 patients that we looked at. Breaking that down a little bit, we had 178 users, respectively, of the sea leg, the Orion, and the Plie. One of the early limitations of this exercise is that we only had outcomes from 68 users of the RIO, so the RIO was a little bit underrepresented in our analysis. As you look at the various demographics here, things like age, height, gender distribution, amputation etiology, we see that the demographics between these four groups was largely very similar. There were some subtle differences here and there. I'll highlight a few of those. C-leg users were on average a little bit older than the users of other microprocessor knees. The relative percentage of female users was a bit higher for the plie than for the other knee types. And then RIO users were more likely to report being employed. But generally, very similar. So with that basic understanding of the patient demographics, I'm going to go ahead and turn it back over to Shane to speak to some of the results that were observed in the analysis.
Thank you, Phil. So as mentioned, we focused on 4 different measures: mobility, which was captured through the +M, and then satisfaction, quality of life, captured through the PEQ, well-being. And then the last construct was injurious falls, captured through that singular question that asked for injurious falls over the previous 6 months. First, let's take a moment to review the findings for mobility, quality of life, and satisfaction. Looking across the bottom of the slide here, from left to right, so first you'll see the results for mobility, followed by satisfaction, and then quality of life. Within each of these figures, the groups you're seeing from left to right: C-leg, Orion, plie, and last, RIO. Now, in terms of mobility, on the left, overall scores followed a normal distribution with averages close to 50. This is consistent with actually the design of the +M instrument. When comparing the knee groups, there were non-significant differences. However, recall that this is patient-reported measure of mobility. So it's possible that you may see differences in a physical performance measure of mobility, although this would indicate that those differences may not be perceptible to the patient. For satisfaction, although the median satisfaction was lowest in the plie group, there were, again, no statistical differences. For quality of life, on the bottom right now, the groups followed a similar pattern of satisfaction, but here the plie was actually significantly reduced compared to the C-leg. On our next slide, we further divided our groups based on patient age. We hope this begins to establish an idea of benchmarks for ages of different prosthesis users. So again, we looked at mobility, quality of life, and satisfaction. For satisfaction and quality of life, there were only non-significant differences. So what you're seeing here are the results for mobility, where we do actually see a few different differences. From left to right, again, C-leg, Orion, plie, and RIO. Now, the groups were then further divided based on their age. So in orange, you're seeing the individuals that were aged 35 and younger, followed by 35 to 49, 50 to 64, and then lastly in blue are the individuals that are aged 65 and older. It was only for the C-leg and plie that significant differences were noted. In particular, with older groups, there's a reduced mobility compared to the younger groups. Now, these differences were not seen in Orion and RIO users. However, when looking closer, the differences for C-leg and plie may be partly driven by higher scores in the younger groups as opposed to reduced scores in the older groups. Recall, though, when looking at this data, this is a retrospective cross-sectional analysis. So that makes it a challenge to understand potential causation for these differences, as there may be a degree of selection bias with regards to how clinicians choose the knee for certain individuals. And then the cross-sectional element doesn't really permit observation of change over time within a single individual. Again, though, that said, hopefully this data begins to help with understanding a little more with regards to benchmarks and standards. On our next slide is where I really want to take a moment to focus on our final construct, and that's injurious falls. To assess injurious falls, this is where we're assessing the prevalence of the individuals that responded negatively to that injurious falls question that we administered. Because the question asks a recall period of 6 months, our sample subsequently dropped to 419 due to additional inclusion criteria that the individuals needed to be on their microprocessor knee for at least 6 months. This ensured that the recall period covered only the time they were on their current microprocessor knee. Using chi-square tests, we compared the prevalence of injurious falls among different groups. In the figure here, you're seeing our results. So again, from top to bottom now, C-leg, Orion, plie, and then RIO. Each of the person figurines that you're looking at represent a 5% increment. So a red person represents 5% prevalence of individuals incurring an injurious fall. When we compared across these groups, there were non-significant differences, with the lowest prevalence among the sea leg at just under 6%, followed by the Orion at about 9%. The Plie and Rio had prevalence of just over 13 and 14%, respectively. Now, while the differences were not enough to reach statistical significance between these groups, when we added the additional comparison group of a cohort of non-microprocessor knee users, which had a prevalence of just over 16%, as you see, we saw that the prevalence of injurious falls for sea leg and Orion were statistically reduced from the non-microprocessor knee users. The prevalence of injurious falls for the Plie and Rio were not so different from the non-microprocessor knee that they were able to reach that statistical significance. Now, as we transition to our last slide, putting all of this together, let's really take a moment to just focus on, what is our take-home message?
Yeah, thank you, Shane. So before we transition to Q&A, let me take just a few minutes to provide a summary of our findings. Perhaps talk a little bit about what the implications of this work are, both for clinicians and also for our colleagues and industry partners. I think we want to again articulate that OASIS 1 is not an event. OASIS 1 is a process. It is the beginning of a process where we will follow OASIS 1 with a series of manuscripts that are looking at similar topics. But let me begin by talking about the limitations of this retrospective cross-sectional analysis. Every study, every manuscript has limitations, and the important thing, of course, is to understand what those limitations are and to acknowledge those limitations. And certainly, our analysis, this cross-sectional analysis, allows for understanding of effectiveness as opposed to efficacy. As Shane articulated, we're not forming definitive or making definitive statements on causation. However, with a cross-sectional analysis of 600 plus patients, one is able to talk about association and certainly make statements about association. In terms of acknowledging selection bias, an obvious area that we would comment on would be the unequal sample size of Rio users. We would also share that we did not identify experience or duration on an MPK. Therefore, some individuals in the study may have transitioned more recently than others from a non-MPK to an MPK. But despite these limitations, as I say, every study will have limitations, and despite these limitations, this is, we believe, the largest independent analysis of outcomes associated with microprocessor knee use. We have reported, and our data indicate, relative parity among users of the 4 most commonly prescribed and utilized MPKs with regards to prosthetic mobility, with regards to satisfaction and quality of life. As Shane has just outlined, in contrast to mobility, neither satisfaction nor quality of life values were reflected declines with aging. In relation to the reduction of injurious falls, we have reported that when compared to non-microprocessor knees, significant differences were observed across the 4 MPK types. So what are the implications of this study? What does it mean? How is it applicable to our practice? I think that as I'm sitting watching, questions coming in from literally the several hundred participants in this webinar, I would suspect in a few minutes we will be asked to comment on implications as it relates to the clinic room and clinical practice. But let me talk just a little bit more generally initially around what I believe some of the implications of this are. I think as a independent provider of clinical services, we would hope that future product introduction in this domain would include some data on these constructs or on similar constructs or similar constructs at the point of product introduction or before product introduction. I would suggest that we're at a very, very pivotal point in our profession where And I think an analysis of, or something that we can talk about, is certainly for those of us in the US, is the current experience relating to the coding or the recoding of prosthetic feet. And, and what we're seeing currently is, prosthetic feet being categorized essentially based on their mechanical attributes, not the therapeutic benefit or the clinical outcomes that those individual prosthetic feet, provide. We would therefore, I think, ask and request that there really has to be a paradigm shift. And as we're thinking about, prosthetic components and orthotic components, at this point, we really do believe innovation should be driven by clinical output and therapeutic benefit rather than mechanical feature. In terms of our future work within our group at Hanger, we fully recognize and realize that there may be other constructs and outcome measures that could, in addition to the work that we've done, be used to identify and measure differences in microprocessor knees. As we plan OASIS 2 and 3 and OASIS 4, certainly next steps will include a mechanistic approach to better understand how or if the various mechanical differences of the knee and the knee designs, how does that contribute, or does it contribute to different clinical outcomes and therapeutic benefit. I think we also will begin, and we are beginning to examine the impact of foot and ankle component selection. We're looking at foot and ankle component selection as it relates to the domain of microprocessor knees and knee stability, and the impact, the critical impact that foot and ankle component selection may have. And again, in relation to the comments I made around prosthetic feet in general, we're also taking a very serious look at attempting to define clinical outcome and therapeutic benefit. I can't help but think if the dialogue around the coding of prosthetic feet would maybe be a little bit different if we had independent evidence that we could share that related to the clinical outcomes and therapeutic benefit of these feet, rather than just the mechanical characteristics. So again, I want to just sincerely thank every one of you for your interest and for taking your time out of your schedule to join us today. And with that, I will transfer it back to our moderator, Molly McCoy, who will chair the Q&A. Thank you, Molly.